Thank you, and thanks to the IOP for inviting me here today. So I'm kind of wearing two hats here today. So I'm a clinical radiotherapy physicist in St. Luke's Radiation Oncology Network, but I'm also a graduate student here in the UCD School of Physics. So what is a medical physicist? So we specialise in the application and concept of medical physics to diagnosis and treatment of human diseases, so X-rays, gamma rays, etc., or indeed sealed radionuclide sources. The equipment that we use, how it works, make sure it works properly, then what you get from that, so quality of images, etc., etc. What I'm going to talk about a lot here today is a little bit more personalised. So it's about what happens when you go from the basic physics to putting a patient. And patients are different, and we have a population of patients, and they all respond differently to radiation, etc., and how we really deal with that as physicists. So where do medical physicists work? So you can see here, I work in radiotherapy, and it's by far the majority of physicists work in radiotherapy, and that's just because radiotherapy is a much more physics-intensive pathway than, for example, diagnostic imaging, where diagnostic imaging is a lot more just QA and maintenance of equipment, whereas we involve a lot more in the patients. So what is a LINAC? So it's a very basic linear accelerator. It's the same ones that we have in St. Luke's Radiation Oncology Network. The principles of generating radiation in a LINAC haven't changed over the last few years. You essentially have an electron beam, you accelerate it, hits a high Z target, Bremsstrahlung, you produce photon beams. But what has changed is how we deal with the patient on a day-to-day basis. So this treatment head produces photons. That's pretty standard. What we have here is an amorphous silicone detector. So this now detects these MV photons. So now you have the patient on the bed, and you can look at what comes out the other side. And then perhaps you can look at what happens going through the patient. And then at 90 degrees to this is an X-ray source and a detector. So this is an onboard CT. So in the past, you CT'd your patient and you went off and you planned them, and then they came back for treatment 2 or 3 weeks later, and you hoped that inside they looked the same as they looked before, and you didn't really know. Whereas now we can actually image our patients on the treatment couch before you treat them, and then you can make judgment decisions about whether your treatment's going to work or what you need to address, and you can actually, so you're bringing it back to the patient and their features. So as I said, my talk's called From Lab to LINAC, so we're going to talk about every patient is different. They have their own anatomical quirks. Breathing motion is really important. So patients are not, like physicists like to say things are spherical and of point mass, and you put them in, and you do an experiment, but patients are not like that. They lie there, they breathe, depending on what they eat, they look different inside, etc. Their surface contour is different. Okay, we treat loads of breast patients, but every patient's surface is different, and how do we adapt our treatment for that? And then response to radiation. This is really important. So we know, broadly speaking, on a population basis, what happens when we irradiate a population. But there are outliers within that population, and some people are more sensitive, some people are less sensitive. So how do we adapt our treatment to those patients? So perhaps we're not giving them enough radiation to treat their disease, or perhaps they'll be an early responder and we could not treat them quite so much and therefore reduce the possibility of toxicity. So the first thing I'm going to talk about is 4D CT. So this is accounting for a patient's individual breathing motion. So I have to, escape for a sec. Sorry, this video wasn't going to work. So this is a 4D CT. So what you do is you put the patient on the bed. On their chest, you put a little marker block that has some infrared detectors, and you've got a camera on the wall. So now you're going to, instead of just taking one CT of them, you're going to take a CT that captures their whole breathing cycle. So we're going to look at the motion of this little tumour here as the patient breathes. You can see we have this small tumour here moving up and down. If you look at the heart here as well, you can see it's not just diaphragmatic motion, but you've got the heart beating. And there's quite a bit of motion in this patient. So obviously lung is your extreme example of this. Okay, so this is just another example of a similar lung tumour. So here it is, your distance from soup to inferior extent of your lung is 17 centimetres. you breathe in, suddenly that's 19 centimeters. So you've got a 2 centimeter motion. So in the past, we knew patients breathed, and we had to incorporate that into our treatments. We said, okay, we know this is our tumour, but we know there could be up to 2 centimetres of motion, but you didn't know how any individual patient fitted within that spectrum of motion. So you had to treat to the extreme. You had to cover that tumour with a margin that was going to cover the 95% probability of their breathing motion. Whereas now, with 4DCT, you have an actual pattern of breathing for any given patient. So then this red one is called a PTV, so it's your planning target volume. It's what you plan to. So it's a tumour plus a margin to incorporate all your uncertainties. So there are basic uncertainties, like, for example, to do with the machine and the size that you can set your field. But the main one in lung is your breathing motion. So now instead of having a population-based margin, we have a patient-based margin where we take the extremes, the exhale, the mid position, and the inhale, and we just make sure that we cover that. So now we're bringing it back, and because previously you treated to the 95%, most patients were slightly over-treated. So you can bring your margin down, you can treat a smaller area. So my personal research work then takes this another step further. So we look at, as patients, that patient's breathing cycle goes, there's a probability that the tumour will be found in certain locations more often than not. So I am involved in a clinical trial where we look at targeting dose to the areas where in probability the tumour is going to be on a more often. So that's all well and good, and your plan looks great, and then your patient comes for treatment. So how do you know that their tumour looks like what it did when you CT'd them 2 or 3 weeks ago? So this is where this on-treatment imaging comes in. So ensuring what you plan is what you get in a patient. So these are some very kind of clear examples. So this is pleural effusion. So this is all fluid. So you've now very much changed your density of your lung that you're going to irradiate through. This is the opposite. So you've got a pneumothorax. This is the difference between air and lung tissue in the density. So all of these are really going to affect your dose calculation and the effective path of your radiation. So another example. So this lesion now has a hole in it, so it's not as dense as it was before. So these are some actual clinical examples from our treatment practice. So this is our CT planning scan, and then suddenly you take a cone beam CT and you can't see the tumour anymore. So if you can't see the tumour, you can't really safely treat the patient. So you're going to have to go back to another step 1 on that one. There's another one. So you have this nice CT planning scan, and then you go to treat the patient and their tumour has moved. So now what we can do is you take this planning scan and this scan that you've taken on the treatment bed just before you treat the patient, and you use image registration techniques. So you essentially shift what you planned here over to this, so you're tracking your tumour daily. And the big benefit of this is that then that margin of uncertainty has come down. So you don't have interfraction or an uncertainty from one day to the next because you are moving to match that tumour, so you can now treat a smaller area. So ideally you're going to treat less of the normal tissue. Another example. So tumour's there, we can definitely see the tumour, but our lung density has changed. So we've got this high density here, and that's going to affect, in this case you'd have to actually look at your treatment plan and see where if you have no beams coming in this way, then it's fine, it shouldn't make an enormous dosimetric difference. This is another example of progression. So we have 2 tumours here. This one looks pretty much the same. This one looks a lot different. So you can catch that on day 1 and go back, replan. So it's all about bringing it back to the individual patient and really treating them as a person and trying to use our physics knowledge to improve their treatment as much as possible. This is another case of progression. So this is what we planned. Day 1 looks slightly bigger, and then we just replanned with that increased margin to make sure that we're going to cover what we see. So I'm going to talk a little bit now about kind of I mentioned earlier, the surface contour and how we adapt to that. And this is not my work. This is the work of Kieran Malone, who's another UCD physics graduate. So he recently got a 3D printer, which is really cool, and everyone likes to play around with them. But I'm going to talk specifically about its applications in a radiotherapy clinic. But again, this is about bringing it back to an individual patient and what we can do for their treatment. So this is the basis of a 3D printer. So it's fusion deposition modeling. So you've got your filament here, and it's essentially extruded. Prints are built up layer by layer until a full 3D model is complete. So essentially we create what we want to do on a CT data set, and we export it to our 3D printer. So why this is important is that if you think about MV photons, so if you radiate a block of water, or whatever, so you generate your electrons, but then they deposit dose further down in depth because they traverse the distance before they deposit their dose. So for example, for 6 MV photon, your dose of the maximum dose for a straight on beam is about 1.4 centimeters deep. So if you want to treat something on the surface of a patient, you need to put something that's tissue equivalent on their surface so that you generate your electrons there, so then you're going to deposit dose on the surface. And this is known as bolus material. So this is an example of our clinical setup for our bolus materials. This is our 3D printer here. So we can use this CT planning images to generate a couple of different things. So simple bolus, which is just tissue equivalent material. Modulated electron bolus. So patients can have really bumpy surface contours, which is not great when you irradiate with electrons. You get hot spots and cold spots. But if you could smooth it all out, again, bring your patient back to your ideal physics conditions of a uniform, flat surface, then potentially you can keep your much more homogeneous dose across the patient. And then there's a kind of a third application which we're currently investigating, which is brachytherapy surface molds. Brachytherapy is the use of radioactive sources to treat a patient. So you can customize a mold to fit on a patient and then have little channels where you run a radioactive source through. There are also other random little things that you can do. So this is a phantom here, and we wanted to kind of put a test tumour in it so we could test our system. So we just printed a tumour. We wanted to have some little things to hold our detectors in a nice little location, so we just printed some. This is a customized headrest for a pediatric patient. So in radiotherapy, it's really, really important that the patients are immobilized and kept in a same position every day. And if it's not particularly comfortable, they're less likely to do so. So we printed a headrest to fit his head so that he could be more comfortable. And then you can play around with it and print baby LINACs and things if you want to. So here's an example of this done on a breast. This is Rando, he's our phantom. So he's a whole series of plastic slices with bone and all sorts of things that you can fit detectors, etc. into. So this is our conventional bolus material, which is tissue equivalent, and it's kind of soft and malleable. It requires a lot of tape to hold it in place. And then this is our 3D bolus printed one. And if you look at the CT scan, you can see the 3D bolus one fits a lot better. It's more comfortable for the patient. There's fewer air gaps, so it's better dosimetry. And this is just kind of an application of taking something that we've all seen out there and bringing it back to the patient to make life better for them. This is what it looks like in the system, printing it. And so you can, obviously it's really important, this is a medical grade 3D printer, so it's really important that you get consistent density out of it, because you're assuming that it's essentially tissue equivalent or a known density, and it has to be reproducible. But we do CT all our 3D bolus that we make to ensure that it has provided, or has worked in the printing process. And this is another example. So this is a foot. So after, this is an orphan. So this immobilizes the patient in a reproducible position, but then we need to treat the surface of his skin. So we need to have something to generate that dose. So we'll get dose on the surface. So we 3D printed this mold, which exactly fits on his foot. Okay, so the last little bit that I'm going to talk about is kind of the cell biology. So again, this is about from the population back to the patient. And a really, really simple thing that you probably have heard about is PET. So PET is about biological target volume. So we're incorporating molecular imaging techniques. And a lot of patients, or most of our patients will get a PET scan. So what a PET scan tells you about, it tells you about the cellular burden, the metabolism, but it also tells you a little bit about the function of the tumour. So hypoxia, you can also look at proliferation, and there's some work in looking at intrinsic radiosensitivity and radioresistance. But this is all about bringing it back to the patient. When you give a patient a PET scan, I suppose in about 10% of our patients, it's going to actually change what we do with them, because we didn't see something on conventional CT imaging. And functional imaging just brings a whole new dimension to that. And it's particularly important in lung. So about 30 to 60% of targets are in lung or altered with PET. That's probably more likely that you'll find a little satellite that's too small to resolve on CT, but you can see it on PET. This is something that's always cited. It's quite scary. This is doctors delineating targets without a PET scan and doctors delineating targets with a PET scan. So you can see you're very much reducing your inter-observer variability. And it's all about this. This is what we're all about. Reducing what we treat in order that we irradiate as little normal tissue as possible, and about bringing it back to the patient and prioritizing all we can do for that patient to treat as little of their normal tissue as possible. So this is what it's all about. So it's tumor control probability, normal tissue complication probability. So this gap in the middle is the probability of uncomplicated cure. So you can see if you go up here, we have like 80 for this dose here, say 40 something, you have 80% probability of tumor control, but pretty much no normal tissue complication probability. And what you ideally want is to be able to shift this curve to the right or this curve to the left. And there's lots of ways out there of doing that, but unfortunately a lot of them shift both curves, which doesn't really help because you're not changing your gap in between them. But these are population curves, and what we don't know is where an individual patient sits within these population curves. So here's another example. This is looking at the genetic makeup of a tumour and showing that suddenly, actually, you can split these curves out. So we're not down to an individual patient, but we're splitting the population into different strata. So for this mutated genotype here, you've got a much higher tumour control probability for a smaller dose. And ultimately a smaller dose means less normal tissue irradiated, less probability of side effects for the patient. And a big amount of work that we do in St. Luke's is looking at trying to identify biomarkers that can identify these patients. So for any patient that we have that undergoes a clinical trial, their blood gets taken, and then we physicists take it and we put it in a beam and put it down here and we irradiate it. And then it goes off to DIT and they try and look at the biomarkers. So we're taking all these patients, we're treating them on clinical trial anyway, we're following their toxicity, we're looking at the side effects that we're going to experience, and then we're going to try and look at their blood and see, can we identify something in their blood that predicts where they fit on that spectrum, and potentially in the future either giving them a higher or lower dose. I mean, a classic example of that exists is HPV-related oropharyngeal cancer. So those patients respond way better to radiation than your standard head and neck patients. So there's actually that's now progressed to a clinical trial where those patients get a lower dose than the standard dose in the expectation that they can get a similar tumour control probability, but with a much lower normal tissue complication probability. So to conclude, I suppose medical physics, it involves the applications of physics principles to real life situation, but modern radiotherapy is very patient driven. It incorporates individual breathing, contour, cell biology, all about designing an optimal treatment plan for that patient. And I suppose as a physicist, I like the fact that I'm not just sitting doing physics. I like although it blurs the population, I like adding the patient into it, and it's very rewarding as a profession because you get to see the real impact of the work that you do every day. So, does anyone have any questions?
Hi Cathy, thank you. Very interesting talk. I was just wondering, my own student's point of view, you said there that you're doing physics every day in a slightly different way.
Yeah.
But thinking back to your own school physics, I suppose, what's the one thing that you learned in school that you use the most?
I solve linear quadratics quite often. It's like an equation that you kind of sit down and go minus b plus or minus square root. We use that a lot of time in retreating patients. So it's in working out if a patient's got treatment before and there's an ultimate overall limit to the dose that, say, their spinal cord can get. And then it also matters in how much dose per day they got. So you have to work that all out and put it all back together again to see if their cumulative total dose is over the limit or not. You see, and you end up sitting there with a pen and paper and doing it out. And the other thing that the radiation therapists laugh at us is doing graph paper to make out. We treat a lot of patients with superficial, so kV, so like 100 to 120 kV, so things on your skin, and they kind of are funny shapes, and you have to work out the equivalent area. So you have a graph paper and you're doing a very primitive, drawing your circle and counting the squares and working out what the equivalent diameter circle is for that.
Fantastic, thank you very much.
When you're dealing with the precision that you were talking about there, and like how it's needed to change from day to day, the immobilization for patients must be like absolute, must be almost complete. Basically, has that technology kept pace with the precision of the treatment itself?
It has, yeah. So the thing that you saw on the foot there, so if you're treating a head and neck patient, they would all have that, and patients actually find that quite difficult. So it's a thermoplastic mask, so it's kind of a sheet of grid-like thermoplastic stuff, and then so they lie down in the bed and then you heat it in a water bath and you literally pull it down over them and strap it to the bed, and then it hardens into a mask. So people actually find that very claustrophobic. What I didn't show there is for those lung patients we treat kind of essentially the probability of all regions that their tumour might be in. So obviously ideally, you would just treat during a portion of the breathing cycle, if you could do that, and kind of turn the beam on and off. So we do monitor their breathing traces, and if they breathe outside the trace that they had at CT, then the beam will beam off. But for some breast patients and lymphoma patients, we actually only treat them during a part of their breathing cycle. So they have to do a deep inspiration, which moves their heart away from their chest wall, and then they have to hold their breath for the duration of their treatment. The problem is that most lung cancer patients can't do that because their lung function is not good enough to allow them to hold their breath, whereas breast patients and lymphoma patients, they tend to be in better physical health. So that's an ideal situation, but it's all about, there is a fundamental limit, and we're down to head and neck. If we image daily, it's 3 mils, and I don't think you're really going to get any lower than that, because as physicists, every single thing has an uncertainty from the positions of your jaws, etc., etc.
One last one.
Thank you very much. Roughly what ranges of kilovolts do you use for treating different areas of the body, from superficial to deep?
So for superficial we have 4. So we have 70, 100, 125, and 200. So for superficial skin lesions, we have 4 different energies available: 70, 100, 125, and 200 kV. And then for, I suppose, anything more than a skin lesion, we have 3 different photon energies available. So 6 MV, 10 MV, and 15 MV. But we then also have electron beams. So we have a variety of electron beams. They run from 6 to 18 MeV. Depending on the machines, we probably have 6, 8, 9, 10, 12, 15. So obviously, as I said earlier, we use that bolus to get dose on the skin. But if you're treating a prostate, for example, you use 15 MV because you want to get into the prostate and give as little dose as possible to the skin surface.